Thank you so much for that really nice introduction. And I apologize for my late arrival, but technology, what can I say? So welcome, everyone, and thank you for making the time to spend a little time with me today. So we're going to talk about managing pain, but we're going to talk about doing it beyond pharma. I'm going to touch on pharmacologic management of chronic pain, but I'm going to move into non-pharma options. And I want to thank CC Animal Health for the opportunity to speak today, as they are our sponsors. Before I begin, I want to pay homage to my pain management mentor, Dr. Peter Hellier. Dr. Hellier is a professor of anesthesia at Colorado State University, and he and I, with a cadre of others, were the people who founded the IVAPM, the International Veterinary Academy of Pain Management. And it's been wonderful to work with Dr. Hellier over these decades as we have worked together to move the needle in terms of pain management for companion animals. I always like to start by sharing the fact that I do what you do for a living. I practice. I'm in a small town in northern Colorado. There were about 5,000 people here when I moved here 30 years ago, and we're up to a whopping, I think, 20 or 22,000 at this point. So still very small town. And the reason I mention that is really twofold. One is to make sure that you know that what I'm about to talk about, this isn't pie in the sky, ivory tower stuff. This stuff I do every day in my practice. And two, I want you to really think about, where do you practice? If all of this will work in a small town, semi-rural area of the US, guess what? It will work anywhere you happen to be. In our primary care practice, the Windsor Veterinary Clinic, we're about this. We're about celebrating, protecting, and sharing the special love of animals. Also in this same physical plan is the Downing Center for Animal Pain Management, which is my specialty referral practice. And in that practice, we're all about this. They, our patients, don't deserve to hurt. So what are we going to do about that? As an English major in my previous life, I love collecting quotes from old dead guys. And one of the oldest old dead guys I quote is Galen, who was acknowledged as the first physician. And it was Galen who is credited with saying Divinum est opus sedare dolorum, which translates directly from Latin that divine is the work to subdue pain. So this work that we do to prevent our patients from remaining in a painful state and preventing them from getting there in the first place, this really truly is divine work. Another old dead guy was the philosopher Jeremy Bentham, who about animals said the following, that really the question isn't can they reason or can they talk, but can they suffer? And Bentham was a philosopher at a time when the prevailing thinking was that even if you were a human, if you couldn't speak, you couldn't suffer pain. And that left out infants or people who were deaf and unable to speak, or people who used to be able to speak and had lost their ability. And that's a pretty frightening prospect when you think of it. And of course, animals fell into that category as well. One of my favorite surveys of pet owners was done now almost 20 years ago, but I still love these statistics. When these individuals were asked to say yes or no to certain statements, here's what they said. You know, is your pet a member of your family? 3/4 were willing to say absolutely yes. And 2/3 were willing to say yes to the statement that my pet is one of the most important things in my life. Number 3 is my personal favorite, because for every one of the 53% who went on the record to say, my pet is a better companion than the other humans in my family, you know, there were people in the closet on this. because this is the relationship that we have the privilege of serving. This is my mother, and sitting on her lap is Andre. Now, I had a pretty good childhood. My parents didn't beat me. I wasn't locked in the closet. We always had food on the table. I always had shoes on my feet. And then I met Andre, and I found out what my life might have been like. And when my mother was diagnosed with stage 3B ovarian cancer and given 6 weeks to live, it was Andre who gave my mother the will to wake up in the morning. And it was Andre who gave my mother the vision beyond today's chemo or today's blood work. And when my mother died nearly 7 years after her diagnosis, it was Andre who was with her every step of the way during her time in hospice. And this is the relationship that we have the privilege of serving. And what that means for us is we have lots and lots of job security. We're the only medical profession on the planet that has the privilege of serving our patients from the very beginning of life to the very end of life. From womb, these babies were born about 20 minutes before this picture was taken, to tomb. The whole arc of life, which means that we get to see it all from start to finish. Leon Bernard was a French physician who stated the following: medicine should be practiced as a form of friendship. And that's really what we're about, because friends don't let friends hurt. So a long, long time ago, we used to think that pain was a pretty straightforward process. You put your foot B into fire A, and this pain signal traveled up a railroad track, C, up into your brain, into your pain center. That was such a simple time. Now, of course, we know it's much more complex than that. So when we think about defining pain, we actually need to think about what the IASP has to say. The International Association for the Study of Pain is acknowledged to be sort of the source of a lot of the definitions and vocabulary we use when we talk about pain. And this is their definition of pain: an unpleasant and emotional, put a pin in that, experience associated with actual or potential tissue damage. What I found really interesting is that it wasn't until not that long ago that they added the second sentence, that the inability to communicate in no way negates the possibility that an individual is experiencing pain and is in need of pain relief. And of course, for us, that means our patients. So what about pain in people and pets? Well, it's a complex, multifaceted experience. We have first the sensory informational component. I refer to this as the physiology of pain. But we have the additional emotional component or dimension, and that's the suffering piece of pain. And then finally, we have to think about the cognitive or evaluative component. And this is where we think about our attention to pain, our knowledge of and memory of a previous experience of pain, and what a perceived threat might look like. So why is pain important? Well, Albert Schweitzer said that pain is a more terrible lord of mankind than even death. And there are many, many people each year who choose to end their lives rather than deal with pain that cannot be relieved. The Buddhists state that pain is inevitable, but suffering is optional. And that's really where we come in, because pain is complex and it is intriguing from a scientific from a scientifically oriented perspective. And it is clinically challenging. It's particularly clinically challenging for those of us who work with species who don't speak the same language we do. And many of our patients make pain easy to overlook. Think cats. But here's the bottom line. It's worth making changes in order to improve our treatment, because really what we want is this. We want happy patients. So let me give you some context as to why pain is important in the acute phase, because of the issues we can end up with chronic pain. So this was a study that was done actually quite some time ago, and it looked at perioperative analgesia, and it actually asked the question, can we stop chronic pain before it occurs? So total knee replacement in people. This is acknowledged to be the single most painful orthopedic procedure that people undergo. And in this study, a group of patients were given a continuous femoral nerve block for 2 days versus additional parenteral opiate therapies. So the control group, the non-nerve block group, got standard of care, and these patients got standard of care, but instead of additional opiates, they got this femoral nerve block. Now, it's pretty predictable that in the first 2 days following surgery, of course, they would have improved pain relief, but this is where it gets very interesting, because 40 days later, these same patients had better range of motion, and they were released from rehab earlier than the patients who did not get a femoral nerve block. Now, this was done in 1999. Now, if this scenario is sounding familiar, it should, because we now have Nociceptive. And what does Nociceptive do for us? It provides days of local analgesia in our patients who undergo knee surgery. So what if we choose to ignore pain in its early stages? Well, early pain gives us some benefit. It helps us live by avoiding further serious injury. So it might be kind of a nuisance rather than a big deal, but if we do nothing, we ultimately end up with a decrease in quality of life. Pain can and does become unbearable, and we can end up with pathophysiologic effects, which include death. And the other thing we now know is that, in fact, the spinal cord is no longer known as just a relay station, that train track that carries the signal up to the brain, but it actually modulates the pain experience. And our target tissue here is, in fact, the dorsal horn of the spinal cord. Because again, what we're after, happy patients. So one of my very favorite neuroscientists is a physician named Clifford Wolff, and it was Wolff who really changed how pain is discussed in pain circles. And we used to have all these little cubbies into which we would categorize pain patients. And now with Wolff's help, we know we have good pain and bad pain, adaptive pain and maladaptive pain. So what qualifies as adaptive pain? Well, nociceptive pain. This is that pain we experience when we put our hand on a hot stove and the nervous system says, whatever you do, get your hand off that hot stove or you're going to burn yourself. So this is pain that helps us survive our environment. Inflammatory pain also helps us survive our environment. However, inflammatory pain is our gateway into maladaptive pain. And why is that? Because in the face of unmitigated inflammatory pain, we can end up with spontaneous pain states, and we can end up with a hypersensitivity both to what should be innocuous stimuli, but also in response to painful stimuli. And we typically think of these pain responses happening in the aftermath of actual tissue damage and inflammation. So if left unchecked, we move into maladaptive pain. And the largest category of this is what Wolf has labeled neuropathic pain, which is a spontaneous pain state. And it does reflect hypersensitivity to both innocent and noxious stimuli. The second category of maladaptive pain is one that we in veterinary medicine are probably going to have a difficult time ever really defining, because this is where we have an abnormality in central processing here in the brain. And because our patients who undergo MRI are typically unconscious, we're going to have a difficult time really identifying functional pain. But I would argue that neuropathic pain is the broadest category of chronic pain, maladaptive pain that we deal with in our profession. What we're really talking about with maladaptive pain is this term that we have embraced called wind-up. And wind-up is a descriptor of the kind of sensitization that happens both peripherally in the nociceptors, but also in the central pain pathways, where that dorsal horn actually changes in response to that afferent barrage of nociceptive impulses, and it makes it easier for the body to experience pain. And that's really what maladaptive pain is all about. And this is my cue to remind you that while cats are wired like humans and like dogs, they are not small dogs, as they always remind us. Because again, what we're after is peace and quiet, happy patients who are comfortable. So when we're confronted with a patient who is painful, we need to make a pain plan. And we need to make a plan that starts at the beginning. And you may think that this is really kind of an oversimplification for me to say begin at the beginning, but I review record after record after record of painful patients who've been seen elsewhere, but there hasn't really been a plan that starts with foundational information. So what does that mean? Means a thorough examination with a pain palpation and a neurologic assessment that includes a metabolic profile. We want to complete an appropriate diagnostic plan because we don't want to miss an osteosarcoma that's been treated as osteoarthritis. 3 times I've had patients either referred to me by other veterinarians or self-referred by clients who've come to me with joint pain, with limb pain, where there hasn't been an x-ray, and we have in fact identified osteosarcoma that's been treated as osteoarthritis. We need to treat the treatable, and we need to treat all the treatables. So that means taking into account chronic renal disease in cats or hypothyroidism in dogs. We need to make our plan, write it down, and then work that plan. And we need to be willing to be flexible so that as the patient changes over time, so can our plan change. We now know that chronic maladaptive pain really cannot be treated with monotherapy. There's just no monotherapy that is truly appropriate or effective. When I was first in practice 35 years ago, we didn't really know as much about pain as we know now. And we had not anything like the tools we have now. So when the very first non-steroidal became available in 1997, and that was carprofen, brand name Rimadyl, the veterinary profession thought this is it. It's a miracle. This is the answer to all of our pain, prayers, and problems. And of course, what we now know is that it's just no longer appropriate to throw a non-steroidal or two at a patient. We need to make a multimodal plan, and that means multitasking. And we now recognize that the client is an absolutely essential partner. So where do we start? Well, one of the things that we need to come to grips with is that most chronic pain patients are less active, and they're very often overweight. And the most important PT thing we can do for them, the most important physiotherapy we can provide, is normalizing body composition. Now, I'm not talking about just losing weight. I'm talking about normalizing composition. Because if all we do is restrict calories, we take a big marshmallow and we turn them into a smaller marshmallow. We actually want to change body composition. We need to diagnose and treat hypothyroidism in dogs, and we need to choose a nutrient profile that's been proven in clinical studies to actually facilitate weight loss and redistribution, to upregulate the genes associated with lean body mass, and to downregulate the genes associated with obesity, with the poor body composition. There's really good nutrigenomic data out there for us. So alongside normalizing body composition, we need to break the pain cycle. And we know that pharma is an essential tool at the beginning of this process. We also know that NSAIDs really remain a cornerstone of pain management because they decrease inflammation and they do reduce pain by acting both at the sites of inflammation, but also at various places in the nervous system itself. We also know, despite whatever marketing hype to which you may have been exposed, that there's no best NSAID. There's no one magic bullet non-steroidal anti-inflammatory drug. It's what's best for that particular patient. It's also true that a failure or a sensitivity to one non-steroidal does not necessarily mean no NSAIDs for that patient. Although I will disclose to you that if I have a patient who starts on carprofen and can't tolerate it, and I move them to meloxicam or grapaprant, and they fail that, they have a sensitivity to that, I don't expose them to a third non-steroidal. Once their pain is well managed, then we can circle back to the NSAID and titrate our dose to the lowest effective dose, which often in my practice is 0. We could only do this with a multimodal plan. My friend and colleague at North Carolina State University, Dr. Duncan LaSalle, did a really elegant study in which he asked the question, with nonsteroidals as monotherapy, can we really titrate the dose down? And the answer was absolutely not. These patients began to suffer again. It's only if we have a multimodal plan in place that we can do a dose titration. So what tools can we use? Well, remember, I talked about the dorsal horn of the spinal cord, and that means we have to make a targeted plan because chronic pain is maladaptive or maldynic. It means pain as disease. And that dorsal horn is the bad actor when it comes to creating pain as disease. This idea of targeted therapy, where we're going to use a tool that actually addresses the dorsal horn in particular, is a really new concept in human pain management, and it's an exceptionally new concept in veterinary medicine. So the gold standard tool that we have that targets the dorsal horn is this one, gabapentin, and its effect is exquisitely specific. Now, if you look at references that were written as recently ago as 10 or 15 years, you will see under mechanism of action, it will say unknown. Unknown. We know it works. We don't know how it works. Well, now we know how it works because what it does is it actually affects the alpha 2 delta subunit of the calcium channel in the dorsal horn of the spinal cord. So it modulates calcium influx and efflux in the neurons. This is really important for chronic maladaptive pain in people. So if you know anyone who has had postherpetic neuralgia or shingles, they've probably taken gabapentin. If they have diabetes and they have peripheral painful neuropathy, probably taking gabapentin. If you know someone with chemotherapy in their past who has a chemotherapy-induced peripheral neuropathy, they've probably taken gabapentin. The key to gabapentin is dosing appropriately, and that means 5 to 10 milligrams per kilogram, 2 to 3 times a day to start. And we need to do regular reassessments and regular dose escalations to the effect of pain management. It's a lot like dosing pure mu opiates. We know that if you have big pain, you need a bigger dose of fentanyl. And if you have little pain, you need a smaller dose of fentanyl. It's a myth, and I'm still not sure how this got started, that gabapentin doesn't work until you're out a week to 10 days. That's just not true. You'll see effects within 48 hours, 24 to 48 hours, but you'll see peak and steady state effects once you get out 5 to 10 days. It's important to note that in our patients, sedation is the only relevant side effect. And it means that then we reduce the dose. We don't just take it away. The one aspect of gabapentin that's really critical is we have to help our clients understand they cannot stop this drug abruptly. If they stop the drug abruptly, the patient will have what's called rebound pain, and they'll end up more painful than when we started. The other thing that we need to note is that long-term dosing is fine because this drug will not have an adverse effect on the kidneys or on the liver. I had the privilege of having a study published. It is an open article, and it reflects a retrospective study in my practice using gabapentin for chronic maladaptive pain in dogs. We looked at over 250 medical records to make our assessment about just what kind of dosing intervals we used and what kind of actual doses in milligrams per kilogram we ended up using. If you're interested in that paper, you can easily do a search, Downing, gabapentin, chronic pain in dogs, or if you reach back to the folks at Assisi, I'm happy to make that paper available directly. And this is why dogs bite people. So what other tools can we use pharmacologically? Well, amantadine is a great tool. It's an NMDA receptor antagonist, complements the nonsteroidal and gabapentin because it works by a different mechanism. Gabapentin works on the calcium channel. Amantadine works on the NMDA receptor. Dr. Lascelles and his colleagues did a study that was published in the Journal of the ACVIM, which is an open journal if you're interested in the article. And the dosing range that they came up with is 2 to 5 milligrams per kilogram per day. It is well tolerated long-term. But here's the kicker. It's an orphan drug on the human side, which means it's outrageously expensive. So if you choose to use amantadine, you really will need to have it compounded. I actually find that I don't often use this medication anymore because of the other tools that I put into place. Another tool we have available are the polysulfate glycosaminoglycans. And while I am very careful to give unbranded talks, there is only one brand of PS gags that has been approved in companion animals, and that's Adequan. Now, what I'm about to tell you is extra label. Extra label meaning it's not approved for cats, but I've used it in cats for well over 20 years, as have many pain practitioners. It is extra label, so we need to inform our clients. But remember that the PS gags are the building blocks of cartilage. building blocks of cartilage that exists. So adequine doesn't replace cartilage that is already gone. What it does do is heal microfractures. And by healing the microfractures, it actually has an indirect anti-inflammatory effect. Remember that the other things it does, it increases the viscosity of synovial fluid, so it actually makes the joints better lubricated, and it helps to decrease inflammation in the joint capsule. The dosing that we use in my practice is the label dose, which is 2 mg per pound, not mg per kg, mg per pound, but I use it under the skin, not IM, 2 times a week for 4 weeks. Once a week for 4 weeks. That follows the label recommendation. And then every 10 to 15 days for maintenance, depending on how the patient's doing. So if I have a client tell me that by day 13 or 14, they notice that their dog or cat is once again a little uncomfortable, then we shorten the interval and we do it every 10 days instead. I've had a couple of really painful advanced OA patients who have maintained their adequine once a week. Now, the advantage to sub-Q injection is, of course, we can teach the clients to do this. And I always present this by comparing it to giving insulin. Whereas insulin is given twice a day, this only needs to be given twice a week. And that seems to help lessen the blow of the client learning how to give injections at home. The sooner we use it, the better. Remember, it doesn't replace cartilage that's gone. It helps prevent further damage to cartilage that remains, and we can use it long term. It is in the synovial joints, these building blocks, within about 72 hours. And this is one reason why I will use it for patients who have chronic back pain, because remember that each of those facet joints is like a mini knee. It is a tiny synovial joint. Just a reminder, this is what we want, cats who can assume the position. So what about turning our focus to non-pharmacology? Well, we have nutrition and nutraceuticals that are available to us, but we must follow the evidence. So if we choose to use a therapeutic nutrient profile, we need to make sure we're following one that's been shown in clinical studies to actually be effective. Omega-3 fatty acids, we know, have a role in helping with joint support and decreasing pain and inflammation. But we need to remind ourselves that we need to use a triglyceride formulation and not an esterized formulation. The esterized formulation is really easy to make. It's cheap to make. And that's why if you go to GNC, that's what you're going to find on the shelf. The problem is that it goes in this end and it comes out that end unchanged. Right now, there are 3 triglyceride formulations available in the veterinary arena. One is made by Nordic Naturals. The other second is made by Nutramax. And the third is made by Vetaquinol. In order to get a therapeutic dose, it's important to note that you will need to use the liquid. Right now, there are not capsules available that can actually achieve a therapeutic dose of omega-3 fatty acid without the client having to just poke pill after pill after pill. Another player in this nutraceutical market is UC2, or undenatured collagen type 2. I want to tell you a little bit about this because the mechanism is so unique. So in a rat model of osteoarthritis, which is the most common model that's used right now in research, this molecule UC2 slowed the deterioration of articular cartilage. Now, how does it do that? Well, it uses a mechanism called oral tolerance. And in oral tolerance, what happens is we get an immune modulation via lymphoid tissue in the gut. You may remember from decades and decades ago when you were in anatomy that you learned about Peyer's patches in the gut. Well, by exposing those Peyer's patches to UC2, it stimulates a recognition of that type 2 collagen, and that prompts the immune system to create these anti-inflammatory cytokines. And so in the studies that have been done, there have been significant outcomes in humans, dogs, and horses. Another tool we can use is a milk protein that's extracted from the milk of hyperimmunized cows. Yet another very unique mechanism of action. Because what this compound does is to inhibit cytokines, which in turn inhibit neutrophils from migrating to sites of inflammation. And so this blocks the upregulation of inflammation and downregulates destructive chronic inflammation. The beauty of this protein is that it works by a different mechanism than nonsteroidals and steroids, which means it can be used concomitantly with them. And because it takes time to reach its peak effects, we can't really use it for acute pain, but it works great for chronic pain. And what we do is we overlap its use with other modalities. And then once we establish good pain relief, we can then turn our attention to the steroids or the nonsteroidals and begin titrating. Really, the side effects associated with this compound are GI, and I've had a handful and only a handful of patients who really couldn't tolerate it over time. Another tool for us to be aware of is the green lip mussel, or Perna canaliculus. And what's important about green lip mussel is understanding that it does have EPA and other essential fatty acids, but also a palette of bioactive lipids that then can be complemented by hyaluronic acid of a very specific molecular weight that can, in fact, get into the joints, decreasing inflammation and pain. But here's the kicker. It needs to be manufactured in a way that doesn't denature it or interfere with its efficacy. And this is why when we look at nutraceuticals, we in veterinary medicine need to be very, very fussy. It's the formulation that's important, not simply the ingredients. When Perna canaliculus was first investigated as a potential tool for use with patients who have osteoarthritis, every Tom, Dick, and Harry that made a supplement threw green lip mussel into the mix and made the claim, we know that green lip mussel can help with pain and inflammation. We put green lip mussel into our product, therefore it will do what we say it will do. What we need to do is we always need to ask, show me the data. Where are your studies of your formulation in the target species? Because what we're after are happy, pain-free patients. So another way for us to think about non-pharmacology is physical medicine and physiotherapy. So here's a list of the tools that are regularly utilized for helping us with painful patients. And some of these techniques and tools really do require advanced training, like chiropractic or osteopathic manipulation. You really need to be trained. However, many of these other tools can, in fact, be used if you are willing to do some digging. For my money, the most useful book, if I had to choose one most useful textbook for physical medicine, it's the Daryl Millis, David Levine's second edition of Canine Physical Therapy and Rehabilitation. And the reason that I would guide you to that book over any other is not because I have a chapter in that book on pain management, but because these two authors, who are both good friends of mine, were brilliant in that they created appendices that actually provide guidance about creating a pain management strategy using physical medicine for very specific conditions. So I hate to use the word cookbook because it really is about tailoring what we do to meet the needs of the individual patient. But this textbook is something that any practitioner can use to bring physical medicine to the patient in a way that just you've never before been able to do. So one of the techniques that I want to talk about specifically is this targeted pulsed electromagnetic field therapy. Now, it's the little t, the lowercase t, that makes this so important. This isn't about any old electromagnetic field. This is about very targeted therapy. So please allow me to elaborate. The biophysics of this really resonate with my nerd brain, because what this technology does is to increase calcium signaling and decrease production of nitrous oxide. And these two pieces together actually combine to decrease overall inflammation. One of the other details of this technology is that in the face of a fracture, this technology has been demonstrated to increase both the number and the activity of osteoblasts. And one of the things we know is that nobody has the patience for fractures to heal. And sometimes we can end up with delayed healing or even a non-union. And if we leverage this technology, we can actually improve an outcome by speeding the healing of fractures and decreasing pain and inflammation at the same time. So here is a dog who is dealing with a carpal injury and is benefiting from both the pain management and the accelerated healing that happens by using targeted pulsed electromagnetic field therapy. So this technology can decrease both acute and chronic inflammation in a way that's safe and effective and non-invasive. And the really cool aspect of this is that this is something that is done in between times that patient sees you, that patient sees me. This allows a level of engagement for clients that we've really never had available to us before, because it allows our clients to play an active role each and every day that moves their animal toward the ultimate goal of healing or being pain relieved. Now we actually have more data about using different frequencies for both seizure management and anxiety management. And one of the interesting things about this technology, based on the human studies, is that gives us a chance to extrapolate the use of this technology for other inflammation-based conditions. So think about cystitis in cats. Think about pancreatitis in cats or in small dogs. Think about prostatitis in dogs. Think about wound healing. Some of the published data on the human side includes things like this: decreased proteinuria in humans who have kidney issues. So what about expanding our use of this technology for cats with chronic renal disease? Decreased pain following breast surgery in humans. So in this case, women who've had lumpectomy or mastectomy, having the loop incorporated into their bandages decrease their use of opiates in the post-operative period. Decreasing prostate volume. So in human males with benign prostatic hyperplasia, the canine model for this disease was what really led to its use in human medicine, which is why we can consider using it for prostatic disease in dogs. And then on the veterinary side, we have now published study about post-laminectomy patients who've had intervertebral disc disease. They've had a surgery and they get better, longer lasting pain relief the longer we use the technology. So someone had the insight to ask the question, what about whole body treatment? Because we know that patients who develop osteoarthritis will often develop it in more than one joint. I mean, that's just reality. So whole body treatment cannot hurt these patients. And of course, cats being cats. First of all, we know that 90% plus of cats 10 years of age or older have radiographic evidence of osteoarthritis in at least one joint. And we know that the majority of those cats have their first radiographic evidence of OA in the lower spine, in the lumbosacral area or in the tail base area. So certainly we should be able to help those cats who are notorious for not wanting to take oral medication by leveraging this technology. This is just an image of the calming application where we can actually get some cranial penetration. It is a different frequency. It is a different electromagnetic field that is used. But the idea that we can provide this kind of relief to our patients by using a technology like this is pretty amazing. So what other non-pharmacology ways do we have to deal with pain? Well, we have assistive devices that we need to leverage and recommend early in the process, whether it's supported vests or wheelchairs, or slings, or in the case of patients who are really having difficult moving, a rolling wheelbarrow or a cart. This is Chomo, and I love talking about Chomo because at 12, she began having symptoms of degenerative myelopathy, and she lost the ability to go running with her family. We put her in a canine cart, and you can see that her feet are on the ground. And that's because early in the use of her wheelchair, she still used her rear legs. She just needed a little help. Within 1 week of getting her cart, she was back running with her owner 3 to 4 times a week. And when she died, she was almost 16, and she died of acute on chronic renal failure. She used her wheelchair until the week before she died. And as she lost function in her rear legs, we were able to sling her rear legs up off the floor, off the ground, so she didn't grind away her toenails. The other thing that we, I think, in veterinary medicine overlook is this, helping our clients modify the home environment and home activities. Every single one of our patients should have their food and water dishes at their elbow height. That means cats and dogs, no matter how big or small. And we need to educate our clients about covering slippery floor surfaces and modifying access to stairs. There are some animals that just shouldn't have unsupervised access to stairs, and helping them know to get a ramp for entry and exit into and out of a vehicle. And again, modifying play with other pets. Don't forget to help your clients know what's the plan. Write things down, be specific, and ask your clients to keep a diary of activities of daily living. What does their pet do? So what is our target for restoration of that function? When we direct our attention toward pain, it's really about identifying trends. So I'm fascinated by how my patient feels today, but I'm far more interested in what happens over a week's time or over a month's time, because that's what's going to guide my therapy. I want to close with a couple thoughts about pain and its relationship to FAS, or fear, anxiety, and stress. When we encounter a patient who is exhibiting what are considered unacceptable behaviors, always, always, always think about pain. Because here's a fact: anxiety amplifies pain, and pain amplifies anxiety. So we can get into a vicious, vicious cycle. The only way we can really address this is to look at the whole patient and ask lots of questions, and then close our mouths and listen to our clients for clues that will let us understand, are we dealing with a patient whose anxiety is elevated and escalated and exacerbated by a pain experience. This is where we can leverage the fact that our clients all have a camera in their pockets and they can take pictures for us. Older dogs and cats may be fearful because they're painful. Here's another fact. Our patients cannot and do not anticipate or fear their own death, but they certainly anticipate and fear pain. And any pet who is reluctant to be handled must have the benefit of our concern that they could be painful. And so if we get a cat who's a bad actor, I'll tell you that almost 95% of the time in my practice, those cats are painful. They're anxious, but they're anxious because they're painful. So please keep an open mind about this. Take a considerate approach. Ask that patient to participate in her own care. Invite that pet to participate because we know that forging ahead will escalate FAS, and that can in turn escalate their pain experience. This is really taken directly from clinical bioethics by treating our patients the way on the human side, nonverbal children are now treated. We have to identify what do we absolutely need today versus what do we want that we could acquire on a different day by paying attention to pain and to FAS. From a bioethical perspective, it is time for all veterinary professionals to be fear-free certified professionals.